Assalamu alaikum. We will continue our discussion which we started yesterday. Dr. Umar, can you just quickly revise the main concerns related to pediatric anesthesia? Dr. Umar, can you listen?
Assalamu alaikum, sir.
Walaikum assalam. Just you were there yesterday, am I right?
Yes, sir, I was.
So if you can just quickly revise in that time, some more people are joining.
Yes, sir, my concern in the pediatric anesthesia was I will divide them into system wise. My concern about the airways, my concern about the cardiovascular system. In airway, I am concerned because the pediatric patient has a. So, may I explain them?
Just
Hello?
summary. Yes, yes. Actually, remember
Yes,
one
sir.
thing, Dr. Umar, try to understand one thing which I was highlighting yesterday, that it's
Yes, sir.
least likely that in FCPS Viva, they will ask you directly this question that what are the anesthesia concern in a pediatric patient? You will
Yes,
get this question in a scenario. Okay. So in the
yes,
scenario, you are not supposed to recall like a book. Okay,
yes, sir.
you have to like I told yesterday, that it will be a scenario that a 4-year-old child known case of Down syndrome is presented for adenotonsillectomy. Like this is an example. Okay, so how will you speak out in that scenario about pediatric anesthesia?
In
And you will have 30 seconds to 1 minute. So
in
you
that
have to,
scenario, yes.
yes. So all questions will be like this.
Yes, sir. So in that
Okay.
scenario, I have concern about uh, mm, being the patient pediatric, being the patient Down syndrome, and the surgery about the tonsillectomy or adenotonsillectomy.
Okay.
About the
Sorry, Umar.
pediatric, I
Again, I am
yes,
interrupting you because, of
yes,
course, we
sir.
are practicing. So,
Yes,
I'm
sir.
just trying
Yes,
to
sir.
tell you that in the scenario, uh, I will exclude only the journal pediatric concerns which you need to remember whenever you are finding a pediatric patient. Got my point?
Yes, sir. But I have a question. Don't I have to tell my points that I in that surgery I'm concerned about these things,
Of
pediatric
course,
as
of
well
course,
as Down
of
syndrome as
course,
well
of
as
course. This is
yes.
mandatory. This is mandatory. Okay,
So, sir, I
but
am going to have a open sentence, opening sentence. In opening sentence, I will tell them, okay, I have these three concerns. Then I will go for the pediatric, or I'm asking
yes,
from you, or I
yes,
will
yes.
go just for the pediatrics.
No, no, it's not like that. I will tell
Yes,
you. The thing
yes,
is
sir.
that you will, in any
Yes,
scenario,
sir.
you will combine like this. Okay,
Yes, sir.
but
Opening
for
sentence.
just because we are right now we are discussing pediatrics. So for pediatrics, like how will you make a summarized answer which can be used for any pediatric scenario? Okay.
Okay, sir. Uh, in pediatric surgery, I have concern about. Sir, I know the points, but I'm not
You
summarizing
got
it
my.
in a one
So
sentence.
yeah,
Could you
that's
please?
that's
Yes,
what
sir, I
you yeah
got your point, but I
yesterday you
don't
did
know
not.
how to.
You
Yes, sir.
yesterday you were
Yes,
not
sir.
there.
Please. No, sir, I was.
So that's what I was highlighting even yesterday.
Sir, I know the points, but I'm not going in
Try,
two sentences. Yes,
try.
sir. I.
Because in the exam, that's a mistake you people do. That's what I am here.
Yes.
Because you will find all the bloody notes in the world. You will find everything written in the books. So why people fail in Viva? This
Yes,
is the
sir.
reason. Because when you have 30 seconds to 1 minute to explain this thing, how will you make it? And this is the same is true for a pregnant patient, same is true for obese patient, so same is true for smoker, same is true for all common patient categories.
Yes.
Try,
Sir,
try to.
yes, sir. In the pediatric patient, I'm concerned about the airways, CVS, and about the drug distribution
Okay.
or volume.
Okay.
So because
What else?
so they have the different respiratory parameters as well as CVS concerns. They have not developed renal system properly
Mm-hmm.
and temperature control. So my main concerns are about these things.
Oh, just a second. Let me just revise and like like in the same like I mentioned this case. So it's a 4-year baby for which is known case of Down syndrome presented for adenotonsillectomy. Okay, so you can speak out that there are altered physiological, pharmacological, and anatomical consideration with reference to anticipated difficult airway, okay, consent related issue, difficult IV lines, heart rate dependent cardiac output, challenging, uh, sorry, challenges in monitoring, okay, uh, this one, titrated, sorry, uh, challenges in monitoring and equipment. What else? Chances of more prone to hypothermia. That's what we just chalk out, the summary. So you will just speak out the same thing. Okay. And then next step, you will go to Down syndrome. So what is Down syndrome? Yes, Umar?
Sir, hello.
Yes, yes. What is Down
Sir,
syndrome?
sir, it's
It's a congenital anomaly
yes, sir.
in which
Congenital
what is
anomaly.
there is a chromosomal abnormality. Okay. Resulting in a patient who has learning or communication problem. Okay. Then they have more like more changes in airway, like there is short trachea, atlantoaxial subluxation, prone to epilepsy. Okay, what else? Hypothyroidism. Then chances of
The congenital disease.
other congenital anomalies. Heart. What are the endocardial cushion defects? Okay, AST, VST. Got it? Any other thing, Zishan? Any common thing with reference to
Yeah.
Down syndrome?
Um, so they can have GERD and GERD, sir,
Yes,
dyslexia.
yes, GERD and chances of aspiration. What else?
But I'm not sure, but I read somewhere that they have more chances of associated leukemias. Their immune system is weak, sir. Yeah. I mean, they're-
Do they have this respiratory problems like OSA?
yes, sir, due to adenotonsillar hypertrophy, sir,
Okay,
and
and
increase
so
chances of respiratory.
Yeah, like what you said, immune. This is to be done, spoken when you have finished with all concerns related to Down syndrome, and still they are asking what else, not to be started. Okay, so usually these will be things related to uh, and because Dr. Umar, what's your name? Because I'm a little reluctant in saying Umar. What's your name, Umar?
Sir,
What's your
Dr. Fatma here.
Yes,
Dr. Fatma.
Fatima. So I hope you understand now. Because,
Yes.
remember one thing, 5 minutes. This is the base of
Yes.
scenario-based answer that you have to, if they want to ask you anything in detail, they will probe. But basically, you just have to uh, uh, tell them what are the anesthesia concerns. Okay.
Yes, sir.
And the third thing will be adenotonsillectomy. So, what are the concerns related to adenotonsillectomy? Fatma, you speak out, and Zishan, if anything she missed, you speak out, please. Yes. What are concerns related to adenotonsillectomy?
Sir, let the Dr. Zishan speak. I will
No,
listen.
no, no. I want you to speak out. You have an exam, or Zishan will appear in front in your place. Don't
No,
don't
sir.
worry. Remember one thing. Don't feel embarrassed. It's for your
Yes,
betterment.
sir.
Just take a deep breath. We are here to correct you. Okay. So if you will speak out, you will correct. Sorry, you will improve. Okay. So just try to speak out. No problem.
Yes, sir.
What are concerns in
What are
EAT?
my concerns in EAT?
Shared airway.
Sorry, sir.
Shared airway.
Yes,
Both
sir.
mother,
Shared.
both mother-in-law and daughter-in-law are working in the same place.
Yes, sir.
Okay. Then isn't chances of bleeding? Try to be very simple. Chances of bleeding. Throat pack.
Yes, sir.
Okay.
Okay, sir. Throat
What
pack
else?
bleeding. Some
Tube,
difficult intubation.
tube. Yes, tube kinking.
Tube dislodged yet kinking.
Okay. Then it's usually you have to choose between a day surgery versus admission. Okay. Because
Yes,
usually
sir.
they are being done as a day surgery. So if there is, because there is a terminology, kissing tonsils. So if the tonsil are too big and they are leading to OSA, so you just have to rule out if there is any thing like that. In that case, it's better to admit the patient. Otherwise, usually they are being done as outpatient. This is day surgery. Okay. What else? There are chances of post tonsillectomy bleed.
Stop bleeding.
Okay.
Okay.
It's a painful procedure, and there is there is a difference in technique. Words is cold versus hot technique. So cold in which they crush and they are using less cautery. Okay, and if they are using monopolar versus bipolar, so in monopolar there are more chances of bleeding. In bipolar, uh, there is less chances of post-operative bleeding. Okay. So whenever they are using monopolar, actually, because it will clot and clot can dislodge. So, so in such patients, what is the coagulation disorder, which is usually not identified by the common test? Yes, Zishan,
Sir, uh, common test, sir.
which
Mm,
is not easy, which is not identified by PT, INR, commonly which we do APTT. It's
Sir,
von
sickle
Willebrand.
cell.
Von
What?
Willebrand. No, sickle cell disease is not a coagulation problem.
Okay, sir.
It's an anemia. Okay. Sickle cell disease is a hemoglobinopathy in which it is, sick. Sickle is for sick hemoglobin.
Yes, sir. So
So it's
von
weak.
Willebrand disease can be diagnosed by coagulation,
No,
APTT, and
no,
bleeding time.
no. So,
No?
sometimes von Willebrand disease, every test will be normal.
Yes, sir. Okay.
Yes, APTT can be changed, but von Willebrand disease, there are certain types of von Willebrand disease. Okay, so some types I don't remember exactly the number, which are not identified by any test. Okay, so now you will just combine it. So if you have to speak out, you will say the adenotonsillectomy in a pediatric uh, uh, patient who has Down syndrome. So airway problems, which will be even more because of atlantoaxial subluxation, short trachea, smaller size tube will be required. So this is a shared airway, tube can kink, there may be bleeding. The concerns related to throat pack may retain. Okay, so it's always important to document when the throat pack is in and when throat pack is out. And throat pack is a source of post-operative pain. Okay, and this is another source, like in addition to what we are saying. And like all the physiological, pharmacological, and anatomical consideration in a pediatric patient need to be considered. There will be challenges in taking IV line, consent, rapport building, there are chances of postoperative bleeding. So that is the way you will speak out in a scenario-based question. Okay. So just a similar scenario, Zishan, now take the lead. Any other exam candidate, please, I would like them to raise the hand so that I will give them the priority. So another scenario, just like that, a patient, um, 2 years old, is presented with stridor. Okay. So what is the differential diagnosis? Yes, Zishan.
Sir, differential diagnosis of stridor uh, uh, could be epiglottitis, croup,
Okay.
tonsillitis, inhaled foreign body, anaphylaxis, uh, uh, the pharyngeal abscess, uh, maybe infectious mononucleosis, sir, very rare. And maybe if the patient has a
If they
burn
put
injury or inhalational
Zishan,
burn injury,
if
that
they
may
put
also represent
if
a
they put
stridor, sir.
Zishan, if they put a pistol on your head and say that speak out infectious mononucleosis, only then you say. Okay? Because in table viva, you don't need to bring any problems for you. 4, 5 points are okay. And then
Yes.
you may classify that if Strider is, what is Strider, by the way?
But stridor is abnormal breath sounds that is visible without stethoscope, sir. That is audible
Okay.
without stethoscope, sir.
Can Strider be functional?
Yes, sir.
Okay, so I have created Strider, very bad Strider, but this is also Strider. So
Yes, sir.
it may be even from psychological to impending airway obstruction. It may be inspiratory or it may be expiratory or it may be biphasic. Okay, it Strider may be post-operative. There will be certain different causes. Then when a patient is presented, if a Strider with the like temporary fever and signs of infection, sepsis, maybe it is acute epiglottitis or this laryngotrichobronchitis. Okay, and maybe there is some history visible, sorry, noted a foreign body, or maybe the foreign body was not like the parents doesn't know about it, that the patient has inhaled. Okay, so the Yajuj Majuj which we have at our home, they are very dangerous. Like my son he was around 1.5 year. He was around 1.5 year. He just put the chicken pecan in his nose, and my wife just saw it. Otherwise, maybe we don't know what's happening. And anyways, it was in the nasal cavity, and we took, and he was just creating some noises. Uh, so maybe, so in such scenario, you have to rule out foreign body as well, because foreign body may be there. Okay,
Yes.
so because this will be maybe of viral infection, bacterial infection, foreign body. Okay, so you can just identify, you can go further with like that. Okay, so what is what is laryngotracheal bronchitis? Sorry, laryngotracheal bronchitis. This LTB.
Sir, I think it is also a bacterial infection of larynx and trachea.
Usually it is
Uh,
viral. It is viral.
okay, sir.
Epiglottitis is usually bacterial.
Okay, sir.
In epiglottitis, there is some epiglottis is swollen like this. Okay, so usually epiglottitis is bacterial, and jo viral is this laryngotracheobronchitis is usually uh, viral. Okay. Okay, so in this scenario, there is another important point which you have to mention, or you have to consider. What are the signs of this airway obstruction?
The signs of airway obstruction can be from
Rather,
very
sign
basics
symptoms.
to
Yes,
sign and symptoms.
yes.
From normal stridor to absolute, it can be from normal stridor to absolute stoppage of the breathing. There could be inspiratory stridor. Patient could be there will be shortness of breath. Patient may be tachypneic, tachycardic, abnormal breathing, and use of accessory muscles for breathing, nasal flaring. And if there is absolute blockage of the airway, patient may have cyanosis and gasping for air. Sir.
Okay, so
These are
you
the.
have told everything, but Zishan, what you did not tell is the respiratory rate and pattern. So try
Yes,
to start with the very simple things, huh? Am I right?
yes, sir. Basics.
So respiratory rate you have forgotten. So if you are thinking, so maybe if the patient is tachypneic, maybe this is a sign of respiratory obstruction. The pattern, if it is obstructive pattern, as these nasal flaring and accessory muscle, this this tracheal tug, these are all signs of airway obstruction. Okay, what we say
Yes.
in a abnormal position. Uh, you see in which they are leaning forward. There is a terminology I don't remember in which this they are leaning forward. Tripod, tripod, yes, tripod positioning. Okay, what else? So the you have to and later on there will be, because airway obstruction may be upper or lower. So upper airway obstruction we are discussing. So lower airway obstruction will be either reversible causes like you can say obstruction, or there is infection. So infection, there is maybe this what you pneumonia. Okay, and so obstruction is maybe asthma. So you can just, I'm just trying, it's very uh, in a simplistic way. Of course, there will be more and more details about it. Okay, so let's have a look on. Just a second. There is a like, article on this. Strider. So you see, viral group, laryngotracheal bronchitis. So in this, you will just a second. So this is what I was telling. Seesaw chest and abdomen recession, subcostal, sternal, intercostal, tracheal tug, nasal flaring. Okay. So rate, frequency, and pattern, effort, posture, arcing backward. I don't know what is this. Tripod position, which I was telling you. Infants grunt to generate auto CPAP. Wheezing can occur with an inhaled foreign body, or maybe there may be stridor. Infective breathing, hypoxemia, and because next, as you mentioned, cyanosis and hypoxemia will develop. Just by the way, what is difference between cyanosis and um, uh, how will you identify uh, cyanosis versus simple hypoxemia? When you say that it is cyanosis, Zishan?
Sir, I think when there is a set limit of oxygen content or HB, when it is less than that, then we can say it is hypoxemia. I think it's less than HB, less with
No, no,
I forgot the exact number, sir. I think
no,
there
no,
was
no.
a specific number.
Question is that can hypoxia, sorry, can cyanosis be obtunded in an anemic patient?
So, maybe
Yes, doctor.
cyanosis is cellular level hypoxia.
Cyanosis is more than 5 gram per dl of deoxygenated hemoglobin.
Um,
Remember one thing, this is a very basic thing. Okay. So if you are not able to answer, it is just like I remember a student who was very angry that examiner does not like my face and they fail me. And when I probe, he was not sure about the difference between bronchospasm and laryngospasm. Okay. So if you think that examiner are your enemy, they are never your enemy. And they will only fail you when you deserve to be failed. So this is one of the question you should be very, very clear that what is jaundice. Okay. And I tell you something, this is a mistake which Fatma just did with reference to sickle cell disease. This is also a very common thing. I have heard this word from so many people. They confuse sickle cell disease as a coagulopathy, and it is not a coagulopathy. Okay. So remember one thing, you will not fail for something very, very big. You will fail for only very simple thing. Like I share this, I don't never forget. I was failed in one of the exam in which I don't know somehow I was doing laser surgery without endotracheal tube. Now I just recall that how in which planet I was when they were asking the question. And in the same viva, they asked me what is eye spec test. Okay, so maybe some students will not remember that they were doing a blunder, and they will come out and they will say, oh, they asked me eye spec test and I didn't know and I failed. So remember one thing, I have a lot of reservation about our system of training, but our exam system is our pride. Our exam is very difficult, and because it's very standard exam. Yes, exceptions are always there anyway. Patient biased or examiner biased can be there anywhere in the world, but don't waste your energy that examiner is your enemy. No. Okay, Zishan, I hope you understand. So try to, if you have this article,
yes, sir.
just or any point, try to be very simple. How will you approach? And okay, next question will be for me, for you, that how will you approach a patient with the stridor or any signs of airway obstruction? What will be your approach? How will you approach this patient? Yes, Ishan.
Uh, Sir, my approach for this patient would be airway breathing and circulation, and
Okay.
consequent call for help. Uh, I will give
Okay.
I will give 100% oxygen to the patient, and I will look for the I will see his patency of the airway. I will check his bilateral breathing and attach necessary monitoring, and I will pass cannula and start resuscitation. I will also call for help. Side by side, I will monitor his breathing and circulation.
Okay. What else? Your voice is mute. Yes, Ishan. So one of them, in addition to what you have told, is with C, signs of poor
Yes, sir.
circulation.
Sorry.
Signs of poor circulation. Okay.
Uh, yes.
Okay. So what will you do? What will be the indications of
Sir,
intubation?
other than after airway breathing and circulation, I will prop up the patient. Sir, indication of uh, intubation would be the danger signs such as with absolute danger sign and symptoms of the patient, and in which there is indication of absolute blockage of the airway,
Mm.
central cyanosis, signs of central cyanosis, uh, patient inability to breathe, and absent breath sounds. When the patient breath sounds are absent, sir, an emergency patient. And so these are the signs and symptoms uh, in which I would intubate the patients. These danger signs.
And like, signs of sepsis, like as I mentioned, that if you are expecting that it is acute this epiglottitis or laryngotrachobronchitis, so
Bronchitis.
that is the thing which in which you have to be very careful, because if you delay, pa- patient can collapse. Patient airway obstruction can occur. So in addition to whatever you are doing, maybe as we say that resuscitation and management will go side by side. You will try to correlate, and you will try to go towards a differential diagnosis. And the things which will help you, one of them will be this any history of infection uh, preceding that, or respiratory tract signs of respiratory tract infection before, sputum, fever, uh, coughing before. You can ask the, and then if you think it's like that, how will you intubate a patient in which you are expecting acute epiglottitis? Is before that, what about steroids and racemic epinephrine? Yes, Fatima, you want to say something? So racemic epinephrine will also reduce the edema. Steroids will also reduce the edema. So you will also start on the lines of sepsis. You will start empirical antibiotic if there are any things like that. And whenever you are trying to, it's always, you should be inhalational induction, and you should be ready for tracheostomy. Okay. Because this patient can have airway obstruction anytime. Of course, ENT team will be on board. So you might need to have tracheostomy. So it's always, you might end up in having tracheostomy. So it is always advisable to have inhalational induction with spontaneous breathing. Try to conserve the spontaneous breathing. And actually, this is the same approach is even for foreign body. If you have a foreign body, even then airway foreign body, your approach should be the same, because in three things you need. One will be rigid bronchoscope. Okay. And of course, you might need to have sleep fiber optic, because pediatric patient may not allow you to have awake fiber optic. Am I right? Yes, Zishan. We cannot hear you, Zishan. You are mute.
Mm. Hello, sir. Little bit problem with the internet, sir.
Okay. Okay. So I just said that you might need to have inhalational induction. You should be ready for tracheostomy. The ENT surgeon should have this rigid bronchoscope. Maybe you need to have sleep fiber optic. Okay. And
Yes.
the basic theory should be that should not uh, paralyze the patient, or you should not uh, this you should not lose the this one spontaneous breathing. Bilal, are you free? Because this is your topic actually. Would you like to speak out something, Bilal, about management of airway obstruction, upper airway obstruction or lower airway obstruction? Bilal, are you here? Actually, Bilal Tufail is in US. He has done fellowship in advanced airway, and very good. So Ritij, there is no registration. Okay, this is for all of you. I'm at work. Okay, okay, no problem. So uh, okay, so these are some basic.
Sir, can we
Yes.
tell in this that the name of the rigid bronchoscope, or we should like keep it simple? Can we say that there is a Storz bronchoscope in which the patient is ventilated also through that bronchoscope, and shared airway? So there is a less time and patient can desat. Clear communication between surgeon and anesthetist regarding the ventilation of the patient through rigid bronchoscopes. Should we tell this in this too, sir, if we are telling this?
Yeah, I think yes, we can. Bilal, the topic which I was just giving them my insight is upper or lower airway obstruction, and what is the general approach to handle such case patient in which there is stridor or signs of airway obstruction. And so we just discussed that we will be going, our approach will be airway breathing circulation. We will be like, if there is clear uh, like sign symptoms or history towards something or airway, because maybe it is presenting as an airway obstruction and there is no clear history of foreign body. So it may be an infective cause like viral or bacterial infection. It may be foreign body. It may be like reaction to some medication leading to angioedema. Even angioedema can have obstruction, airway obstruction. So this will be your approach to handle it. So like you will be ready for tracheostomy. You should have. I don't think so any problem with using having rigid bronchoscope, and you might need to have like sleeve fiber optic. And what will be the role of supraglottic? Supraglottic may be helpful in some cases, but usually, if you have like in these patients, if there is airway obstruction, like there is subglottic edema, even supraglottic airway devices may not work. Okay, and then the last thing you should mention, or you should have an idea, that will be high frequency ventilation, jet ventilation. Yes, Bilal. Of course, we will, because actually in the scenario, they will, okay, maybe we can take signs of, like, sign symptoms of upper airway, because Bilal is saying that we should take one scenario, one by one. Upper airway. So in upper airway, what will you do? Angioedema. Yes, Zishan, what will be the uh, concerns related to angioedema?
Sir, the concerns related to angina will be our airway concerns. Sir, patient could develop partial or complete airway obstruction due to angioedema. So it can be an emergency situation, and it can be urgent situation. So it should be discussed with the ENT surgeon regarding the conduct of the surgery, sir. And then angioedema can have global effect on the other systems of the body, uh, uh, include hypotension, hypoxia, metabolic acidosis prolonged. So we have to maybe resuscitate the patient, and concomitantly with the management of the airway. And then it might be the tube might be difficult to pass, so we should have a ENT surgeon ready by for tracheostomy if needed in complete obstruction and we cannot obtain a definitive airway, sir. Uh, and
So
sir,
I think
I think
it
these
has
are
the,
the
yes, Bilal, I think this will have the same approach which I was just mentioning, that tracheostomy is a wrong term. Mm, surgical airway. Yes,
yes, sir,
emergency front
surgical
of
airway.
neck access.
Access.
No,
Yes, sir.
emergency front of neck access. Front of neck access. Yes, cricothyrotomy, because that will be percutaneous. What is the medical management? In medical management, steroids, racemic epinephrine. If there is any infusion is going, you will stop that infusion. Yes, I think it's okay. Unfortunately, Bilal is busy, so I think because I'm running short of time. Role of uh, what is transgenic acid? I'm sorry, Bilal. Are you talking about transgenic acid? Transaminamic acid. Yes, transaminamic acid. I have no idea. Is there any role of transaminamic acid, transamine, in angioedema? It reduces production of bradykinin. Okay, so something nice. Okay, okay. So I hope you got it. So yes, Zishan, anything else with reference to this upper airway obstruction? So even in like so I think these are the thing which we can say. I think Bilal, we can have a session on role of nasal endoscopy and how to control secretions. Like this one with the glycopyrrolate. Topicalized airway with the lidocaine. This are you talking about this fiber optic? So like this one would be how to topicalize Zishan nebulization
Mm, It's a
spray
nebulization, sir.
spray.
Spray as you go, sir.
Yes, spray as you go. Individual blocks can be given, but he's talking about nasal. So uh, do you use Bilal there cocaine or any like decongestant alongside this xylocaine nebulization, xynosine
Right, sir.
spray? Yes, actually xylometazoline nasal drops will be used. Xylocaine gel, yes, but you need when you go down, you need to have gargles. This either gargles or spray. Because in this scenario, pediatric patient will not give you that much cooperation. Usually, it is either 4% or 10% spray. We discussed many times this thing. So if it is 4%, it is 40 milligram per ml or 200 milligram per ml. And usually it is different, but usually 1 ml is equal to 10 puff. So, and here the relatively higher dose, maybe you can give even up to 9 milligram per kg. Okay, so you can have uh, yes, up to 9 milligram per kg. Okay, so okay, so I think Bilal, if you are free tomorrow, we can yes, we can get your time in much more detail. Unfortunately, I have to leave. So, you can cover this topic with reference to upper as well as lower airway, and even you should be knowing about handling the foreign body. Okay, so we will just have a look. Will there be any role of Heliox? Yes, Ishan.
Yes, sir. They say that it decrease the density of the combined gas, so flow becomes more less turbulent and it can reach more easily than air and oxygen, sir.
Okay, so but what is the limitation?
Limitation. I think FiO2 gets decreased, sir, with the
Yes, we
oxygen.
cannot because usually it is 70-30 or 80-20. Okay, so maximum it is like that. So you cannot if you want to give higher FiO2, you cannot. Okay, so in foreign body there are certain things, early versus late presentation, size, shape of object inhaled, whether it is any chemical in it. Okay, site of object, within the airway, time of presentation since event. So sometime it may uh, uh, like we are not even, it is presented with airway obstruction, airway symptoms, and actually you are not sure what it is. Okay, so in radiology can help. The thing is that you should not try to overdo in the emergency, because maybe partial obstruction can become complete. And another concept you should not forget, if it is blocking the upper airway, you will try to push the foreign body, okay, so that the acute obstruction is gone. Am I right?
Yes, sir.
Okay, so these are the things, like this is a very commonly asked scenario with reference to pediatric patient. Okay, so we have covered a lot of things with a reference to it. You see X-ray, okay, gas trapping due to ball bone. So ABC, effective cuff or not, this is an important thing. If the patient conscious level is obtunded, that's something critical. Okay, so actually majority of things will be the same. Of course, it will not respond. Usually, can infective symptom be there in a foreign body? Yes, Ishan. Yes, because if it is prolonged history, maybe it get infected, and maybe you can have some fever, or so sometime it will be a tricky decision. Okay. Yes. So if they are asking you this question, so you will say the same pediatric anesthesia concern. You can speak out in a summary, and then yes, you see that they have written the same thing, inhalational induction, because this is an old article, so they have written about halothane as well, but usually sevoflurane. Okay. Mm, I have spoken out. I have explained to you almost the same things. So uh, laryngeal edema, it can damage. So even if sometimes if they have removed the foreign body, after that maybe you need to have a check fiber optic. Okay, so a number of time when airway is secured, either through you are ventilating through side port of bronchoscope, either you are having a jet ventilation. Jet ventilation is a very interesting thing. I have some experience of doing jet ventilation. And what is Zishan, because the more it's least likely to be asked in too much details, because it's a separate full topic they can ask you. But if they are asking you in this scenario, you should be knowing about one thing. What is the problem in high frequency ventilation?
Sir, you
You know
cannot do
about,
exhalation. Breath stacking can take place passive.
don't use this if you say that you
Hypercapnia
cannot. Yes,
cardia.
sorry. Yes, who is speaking? Yes, Fatima. Nusse. Who is speaking? Okay, Zishan, continue. Because if you use this word that we cannot do is a very hard word.
Difficult to convince.
It is one of the problem that it can cause the CO2 retention. Okay.
Yes.
So if in that one, we will try to reduce the rate. If you will reduce the rate of jet, okay, and maybe in between you can deflate. You can stop jet ventilation and open up the airway, so that the this is because jet ventilation is being used in laser surgery, okay, tracheal this subglottic stenosis, when they are doing a repeated procedure, because maybe this obstruction is either this idiopathic, or it is because of some suicidal corrosives trauma. related and if it is prolonged ventilation. So there are so many causes about this thing. So jet ventilation is a good technique in such patients. And but here, even in airway obstruction, if you are not able to properly ventilate with a small, maybe jet ventilation can have some role. Okay. So
Yes.
risk of aspiration, risk of edema, role of steroids, role of antibiotics, sepsis guide lines of sepsis, tracheostomy, or as Zishan was sorry, Bilal was mentioning, front of neck access, or this percutaneous tracheostomy. Okay, and that's it. Okay, so I think tomorrow, inshallah, we will continue because this was a very important topic, airway obstruction. So you can expand yourself. The basic theory will be the same. You will look for as any history, and then your approach will be according to the patient condition. You will look for any signs of airway obstruction. Your approach will be airway breathing circulation. You might need to try some steroid, racemic epinephrine, early intubation, use of anxiolysis, as inhalational induction, anti-salagog, um, that. These are the things which you need to speak out when you are answering this question. Okay. So read about lower airway obstruction. I think because if it is pneumonia or it is so bronchospasm, that is we will discuss later on. Okay. So I will stop here and inshallah we will continue pediatric tomorrow. Okay. So I hope
Okay, sir.
some of you get benefit. Zishan, try to read the rest of the thing. Actually, this topic I had not discussed in too much detail before. So I just try to cover it up. You can have this link and you can have a look here in here, or you can go here and you can go in the airway. So you can find some of the points about airway obstruction here. Okay. So
Okay, sir.
okay, so thank you very much. We'll inshallah continue tomorrow. Bye bye.
Thank you.